Pell Center. My name is Jim Ludis. I am the Vice President for Public Research and Initiatives here at Salve and Executive Director of the Pell Center. It's my pleasure to welcome all of you for tonight's program. While we still do have programs, note that the bios for tonight's speakers are here. But there's also the one last sad little event that we still have planned for this semester, which is on April 25th, 6:30 p.m. here. It's the John E. McGinty Lecture in History, The Rise and Fall of Mikhail Gorbachev and Their Lessons for the Putin Era with Dr. Bill Taubman from Amherst College. It ought to be a remarkable night, and I hope that we'll see some of you there. I've been here at the Pell Center since 2011, and typically the kinds of events that we host are typically focused on foreign policy, national security issues, politics. This is the first event that we've done, in my tenure anyways, that's focused on LGBTQ plus issues, and I can assure you it will not be the last. We have been helped in really bringing tonight together by two fabulous colleagues from here at Salve Regina University. Dr. Julia Europa is Assistant Professor of Nursing here at SRU. She teaches aging and end of life for undergraduate students, ethics for advanced practice, nursing for graduate students, and she's also a faculty fellow in diversity and on the Diversity Inclusion Task Force. She's developed courses titled Interprofessional Perspectives in Healthcare Delivery and Focus on Healthcare Disparities. Her colleague, Dr. Kaitlin Gabriele-Black, is an assistant professor of psychology here at the university. She teaches courses in developmental psychology, research methods and statistics, and diverse families. Her research areas of interest are in the intersection of gender, sexuality, and faith, specifically evangelical Christianity. She's a fellow with the Davis Educational Foundation researching LGBTQ plus medical and mental health resources in Newport in partnership with the Health Equity Zone of Newport and SRU student researchers. So I want to thank them specifically for really being tremendous colleagues and leaders and bringing together tonight's panel. And I'm going to turn it over to you to take us away. So thank you very much.
Thank you for that lovely introduction, Jim. I want to welcome a couple of panelists that I personally know and wanted to share with you all tonight. Dr. Timothy Cavangh works as a family doctor and member of the transgender health team at Thundermist Health Center in Woonsocket. He served as a medical director for the transgender health program at Fenway Health in Boston, Massachusetts, from November of 2012 to May of 2018. Prior to that, Dr. Cavangh worked 18 years as a staff physician and the one-time medical director at Family Health Services and Comprehensive Community Action Program in Cranston, Rhode Island, where he began the formal outreach to transgender patients in coordination with local transgender support organizations. He's a graduate of Dartmouth Medical School and Princeton University. I also want to welcome Mr. Freeman Freeman, graduated from the State University of New York with Masters in Social Work in 1978. He has extensive experience in private practice as a clinical counselor for community mental health, crisis intervention, and sexual trauma. Mr. Freeman also serves as a representative from the Rhode Island chapter of SAGE, which is Services and Advocacy for Gay Elders. He also served on the Board of Governors for Rochester Psychiatric Center and Town Board Councilman for Yates County, New York, among other civic and professional endeavors.
And Melissa Manley is a fourth-year doctoral student in clinical psychology at Clark University, which is where I met her. She studies LGBTQ families and sexualities with a particular focus in bisexuality. She's co-authored several papers on the experiences of women with diverse sexual identities and histories, and her master's thesis is focused on male-partnered bisexual women and their experiences with LGBTQ communities. And she hopes to work clinically with LGBTQ populations in the future. So we're going to jump right into questions, and I'm going to ask the first one of the panelists, and we'll just kind of work our way down the line here. So could each of you please speak to the changes that you've seen in addressing LGBTQ health since you started working in your respective fields?
I jotted down a bunch of notes so I wouldn't forget to talk about things, but as I'm looking at my notes, what struck me is I started medical school in 1983, just as HIV and AIDS was really starting to be sort of defined and identified, and started sort of to come out and sort of begin my life as a gay man at the same time. So, HIV has really kind of, in some ways, I have sort of occupied both my professional and my personal life kind of in the shadow of HIV over the past 30-some years. And I started thinking about how that has really kind of impacted my own practice and the changes that I've seen there, and that, without wanting to pathologize sort of gay male identity and LGBT identity, I think, the HIV epidemic has brought us to where we are in terms of LGBT health. And I'm not sure that we would be up here talking about this if it hadn't been for HIV and AIDS and sort of the activism that came out of that and the demands for people who had been previously stigmatized for respectful care and good care. And now working in trans health, I'm seeing sort of similar kinds of stuff. I think, trans health is probably about 10 to 20 years behind LGB health, I think, in terms of kind of where we're at in understanding and acceptance. And over the past 10 years or so, as I've been working in trans health, I think it's also this kind of progression of sort of people demanding and sort of forcing their healthcare providers in some ways to kind of recognize who they are and to take their healthcare needs seriously, and also thinking about how that really expands. At dinner, we were talking about how working in LGB care really helps me to sort of kind of explode some of those boxes that help me to be a better healthcare provider to all of my patients, not those just identified as LGBT patients. And so I think about how medical care in general has been kind of spurred by the discussions around sexuality and identity that came out of both the gay and LGBT health sort of movements, and now are kind of coming out of the trans health movement.
Again, my name is Freeman Freeman, and when I think about the question of the changes that in addressing LGBT health care and health issues, the very fact that we are here and that you are here is something that would not have happened 10 years ago. So just public awareness, just the willingness of you who are here and we who are here to come together and talk about health care in all of its aspects, not just the direct service that we get from you, but the political arena of health care, the societal arena of health needs and health care, and how all that impacts on how I live my life. When you were talking about HIV and AIDS, I too came of age a little before that, but knowing that my future would, in having my health care needs met, would depend upon how things were accomplished or dealt with during the HIV/AIDS crisis, I decided that the only way I could know that is if I participated. And when they were looking for volunteers for the HIV vaccine trials for a whole decade, every week or 2 weeks, whatever the protocol was, I was there. Use my body safely, but in the service of providing whatever information we could to bring this crisis under our control and management. And I would see, when I would be a part of the buddy system, to go to the hospitals to see men and women who were dying of this disease because nurses, doctors, parents, family members would not attend. So who would go and sit with them while they were dying, or sing with them, or cry with them, or be as scared of them as I was of myself? I didn't do that for any self-heroic aggrandizement, but simply because this was my community. and this was my investment in it. But the very fact that I can find the words to share that with you and feel absolutely good about that, and that you are here to listen and to question and be curious, that is one of the things that have changed in helping to address the health needs of the LGBT community. I work with SAGE, which is Service and Advocacy for Gay Elders. I am an elder. There is a very discrete service needs for the elderly, the gay elderly, because we grew up in a silent generation where I didn't have the language to even know about my sexuality, my orientation, my gender identity, and I didn't know anyone else who knew about it. And I was always living with a hypervigilant notion of, what are they saying? Who said this? What could this be like? Is that about me? Is that who I am? And my identity of myself as a whole person did not come from within me, but was forced upon me from societal's judgments and views about the issue of homosexuality, from it being a sin to it being criminal to it, you being marginalized, or all the things that we already know. So those were traumas inflicted upon me at an early age, but that I can be here today and we can talk about the traumas. That too is addressing the health needs.
Hi. So I, being a graduate student still in the field, certainly have fewer years of experience to reflect on in answering this question. But what really came up for me when I was thinking about this is about kind of how, just the social and legal changes that have happened in the last few years, even from the time when I was teenager, college, through graduate school now. There's been so much change happening in a very short time, and especially for the areas of interest that I have, like bisexuality. More people are identifying as bisexual than I think ever before, especially more young women are reporting same-gender attractions than there used to be. People are identifying themselves as LGBTQ at an earlier age than in the past. There's more protections in most states for LGBT families than there used to be. And at the same time, these things are still very contested. So, we don't have don't ask, don't tell in the military anymore, but we do have current transgender military ban. People may be more free to identify as bisexual or identify their sexuality as fluid, and there's still a lot of stereotypes, a lot of ways that those identities aren't supported and can be written off by different people and still very invisible in a lot of ways. So I was kind of thinking about that kind of proliferation of identities, the ways that we are starting to deconstruct some binaries and create more room for different expressions and different identities, and the ways that these are still kind of really hotbed topics that there's still a lot of work left to do.
Thank you. What I didn't mention in the beginning is that we're going to have a question and answer period at the end of our structured questions. So if you would think of your questions, and then we will ask you at the end of our session. Could each of you speak to your professional and personal experiences related to mental health needs specific to the LGBTQ plus community?
So mental health area. So definitely mental health needs, area that I do research in, very aware of research in. There's elevated rates of most types of issues in LGBTQ community. And also want to note those aren't kind of equal across all identities. So I'm sure we'll hear more about trans issues, but certainly trans people tend to have higher rates of suicidal ideation and attempts and higher rates of violence against them than other areas of LGBT communities. And bisexual people tend to have higher rates of depression, anxiety, substance use than lesbian or gay people. And so kind of recognizing the ways that those mental health needs are not kind of evenly distributed within the community, where the resources are, where access is, also isn't equal throughout the community. There's very few organizations or resources specific to bisexuality. Also, few related to transgender health, though I think that's increasing somewhat. But yeah, kind of thinking about the ways that these issues are intersecting also with other identities, race and class, and how that affects needs and access to mental health. So bisexual people also tend to have more people living in poverty than other sexual identities. And that also affects access to mental health. So kind of just thinking about all of those things and the kind of mental health stories that I've heard from people who have worked with different therapists and been told that, oh, you're confused, oh, this is kind of a symptom of pathology that you are having same-gender attractions, maybe it's a result of trauma. Those things do still happen in therapy, that even when people are able to access a therapist or provider, there still can be a lot of stigma and a lot of negative experiences. Conversion therapy is still a thing, although there are more laws now that are outlawing that for minors, and there's no way to outlaw conversion therapy for adults. So yeah, kind of just, those are the main things that kind of come up for me in thinking about the mental health needs for LGBT community.
So for 28 years, I've been in private practice as a clinical psychotherapist, and I've certainly had my share of LGBTQ plus clients, as well as having brought myself to the same place of saying, I've got to get into therapy, good, bad, or indifferent, I've got to get into it. It was life-saving to me, it really was. Because when you think, when I recognized that when I first became aware of my sexuality as a gay person and had to deal with the outside forces and the traumas of that, and to become hypervigilant, to be careful, to lie, to deceive, to not pay attention, to have other ways of dealing with what I felt was the damnation of being. I did not know who I was, and I was losing every time I had one of these traumatic experiences, a part of my knowing who I am. And so when I would see LGBTQ plus people, I recognized that there is an enormous amount of loss in their lives and coming to even think about, to say nothing of knowing about their sexuality that was different from what was perceived as the norm. And so with that, the mental health needs dealing with loss and grief, just of the self. And then to imagine if my family found out, I would lose them. If my church found out, I could lose my spiritual or religious self. The amount of loss available was just overwhelming. And so, of course, people would hide in, make themselves smaller, lesser, and in many cases, disappear through suicide or other ways where non-existence seemed more meaningful than to exist. So issues of mental health are critical. And so when we see people, as you know, in our helping profession here, we try to see the whole person, not just their sexuality, but we certainly assess what impact does that have on them being the whole person. And what may look like craziness to us may in fact be the person's best coping mechanisms because of the traumas and struggles.
And when I was thinking about this question, it's very similar to what you're saying, Freeman, that I think about sort of this growing conceptualization of minority stress and how the constant stigmatization and discrimination of minority populations leads to sort of kind of negative health outcomes and negative health behaviors, and how those all then sort of feed back into the discrimination and stigmatization, and how we start to talk about sort of syndemic conditions, right? Where depression feeds substance abuse, feeds sort of difficulties with negotiating sexual safety, which leads to higher rates of HIV, which also kind of impacts mental health and depression. And so I think we have come to kind of grasp a better sense of how all these things sort of feed into each other. And I think slowly that kind of helps us to stop pathologizing identity and also some of these behaviors that come out of those stigmatized identities, and that for me that kind of feeds my hope that we can really tackle these things better. From a practical standpoint, I think my experiences in mental health for LGBT communities are really about trying to find competent and sort of accepting and affirming mental health providers and mental health systems, and how difficult that is. I think that's better for LGBT persons and populations now. I mean, you can go out online and actually find plenty of professionals and clinicians who identify themselves as LGB or specialize in LGB issues. I think it's still incredibly tough for people of trans experience to find people who are competent and really don't just throw up their hands like, I don't know anything about that. Like, I don't know anything about gender because God knows I don't have a gender myself, right? And and that difficulty with actually on a very, very practical basis for finding people good, competent care, I think is still a constant struggle for myself in my daily work.
Thank you. A related question, what do you perceive as the biggest barriers for LGBTQ clients in receiving proper medical and mental health care?
I encourage everybody just to be a little bit closer to the microphone.
Sure. So in terms of barriers, we each have been talking and you've been listening and you've heard different words from us, and I have no idea if the words and language that I'm using is heard by you and understood by you the way I intend for them to be. Some people say, well, what's the difference between gender and sexuality, and what is this intersex, and what are transsexuals, and what are transgenders? And so one of the barriers to receiving both physical and mental health needs being met in the LGBT community is trying to find language that we both can agree upon, or that makes sense to both of us, or that you can ask about, So I know one of the barriers is just good human language that doesn't stigmatize, doesn't set up. Someone said to me the other day, oh, well, I accept you as a gay person. And I'm thinking, I don't need to be accepted as a gay person. It is who I am. It's not something outside or separate or an appendage that you need to accept. There's not a benign accommodation of me and my sexuality. But the language people use sometimes is very hurtful and is also a barrier. I mean, am I going to go see a medical person or a mental health person who's going to use language that is an experience of the language I've always heard that allowed me to feel not human? So I think one of the barriers that we are working on, and I hope that when it's time for you to ask questions, any language that you're curious about, or have a misinformation about, or you have heard and not sure if it's truth or myth, that you will have the courage to ask, what do you mean by this or by that? And that will mean that we will both have a chance to break down a barrier that inhibits or stops us from knowing each other.
So one of the things that I was thinking about with this question specifically is about disclosure and how often the burden of disclosure is on the person who's seeking treatment to make it known to the provider that they are LGBTQ, to make sure that the provider has an accurate understanding of what that means, and often to educate the provider about what that means in their life, defining things like, transgender or intersex or, whatever identities they might have. And to some extent that's unavoidable, and just that language is constantly evolving and everything does mean something a little different to different people. But I think it's really important that we move towards kind of opening these conversations with all the people that we work with, and that we try to avoid assumptions or notice the assumptions that we're making when we're working with people about what identities they might have. Especially, I've done research with women who are having children, who are partnered with men, and they'll be seeing a provider, getting like their prenatal care, and the providers will be like, "Oh, tell them, what does your husband think about this?" Or say something about their husband or boyfriend, when they never said that they have a husband or boyfriend. These were all bisexual women, so they very easily could have been same-sex partnered. And then when the provider finds out that they do have a husband or boyfriend, then they definitely aren't going to ask any more questions about what's your experience, what's your history, do you have any other relationships that matter in your life? So that bisexual identity or like whatever other identities people might hold are made so invisible by those assumptions. So kind of thinking about the ways that we do make assumptions when we're working with people, and the ways that we can kind of check that and maybe put that on an intake form. What are these identities for you? What kinds of relationship history have you had? Mm-hmm. And ways that we can kind of open that up and take the burden off of the people who are seeking care.
Yeah, my answer is, I think very similar to yours. I certainly think about, really it all comes down to stigmatization, and that does speak to kind of language and perceptions and, the predominant cisnormativity and heteronormativity of our culture and our medical providers. And I think even for people who identify as LGBT, you're still sort of inculcated into this system that is fraught with kind of all these assumptions, right? So this sort of stigmatization that's both real and also anticipated by patients and by people seeking healthcare, right? That the stories, your past experiences and the stories you hear from other people sort of kind of create a wariness and a defensiveness that really is counterproductive to the therapeutic relationship, right? And how we struggle with that. I think that's a huge barrier. I think we also are struggling right now to kind of come to terms with intersectionality and how that impacts health behaviors and health outcomes, how, people who are, have several different stigmatized identities, and how all of those things kind of impact their health, and how their identity in one community, their stigmatized identity in one community kind of, sort of impacts them, right? So if you're queer and a person of color, when you're in your queer community, how does being a person of color kind of impact how you are treated, and vice versa? And I think, again, from a healthcare perspective, and from a mental health perspective especially, we're really just starting to kind of try to piece together those kinds of problems. I also think that, as is true, I think, of the larger culture, the medical community, and I'm not so sure about the mental health community, but certainly the medical community is really struggling with sort of the concept of queerness, right? And what that means. Sort of speaking to the points that you were making, Melissa, and how to wrap our professional heads around that, and that's difficult for people.
Thank you. Could you please answer what you think the current healthcare and mental health care for the LGBTQ plus community, speaking specifically to advances in healthcare that have impacted the community positively?
Oh, okay. Let me reread the question here. Advances in healthcare that have impacted service delivery in positive ways. Well, when you think about the Safe Zone program, many of you may be familiar. I know for those, the insurer of Blue Cross Blue Shield nationally and Rhode Island certainly has a set of 10 core competencies in working with the LGBTQ plus community that it is suggested that your staff become very familiar with and knowledgeable about and act on. And when those 10 core competencies are reached, you get a sticker that you can put on all of your paperwork and in your offices that say this is a safety zone, which says to people, we know something about what your health needs might be in relationship to your identified sexual orientation and community. That's an advance. So I'll stop with that one. It's the one I could think of right off.
Sure. I think there actually have been lots of advances in the past 10 to 20 years. I mean, again, during the time that I've been practicing, I think, you know, just the wider visibility and acceptance for LGBT people has created, you know, has created better care. Again, I think, you know, going back to that first question, how LGBT people are now coming out and sort of demanding better care has created, certainly created advances in the care that is provided. I think also, you know, it's interesting, I think as more providers now are sort of coming out and identifying that is really an important sort of sign of progress. You know, when I think back to, you know, 25 years ago when I was at a medical conference where, you know, your gaydar goes off and you sort of recognize the other gay providers in the crowd, and you're sort of, you know, kind of getting together afterwards and kind of feeling yourself out and talking about how it was dangerous and hard to be an out provider in the medical community at that time. And I think that has really changed a lot. I certainly think about, you know, in terms of trans health, I think, you know, the greater visibility, there's been a huge, like a skyrocketing rate of sort of research and attention to the medical needs and the healthcare needs of transgender people. It's still not a lot, but compared to what it was 10 years ago, really, again, exponentially better. There are greater you know, more healthcare protocols out there that address the needs of LGBT people, as you're sort of speaking to, Freeman, and just, you know, not just insurance companies, but despite our current administration, the government itself, the CDC and the Department of Health and Human Services, really recognizes that LGBT health concerns and goals for wellness are important and a part of what we all should be doing as practicing. The government for federally qualified healthcare centers now are required to sort of ask sexual orientation and gender identity data and questions. So it compels us to sort of ask those correct questions and you know, not require that people sort of you know, be the one to disclose who they are and disclose what their identities are. I also think advances in terms of kind of LGBT families and sort of the acceptance around queer and LGBT families, again, as you were sort of speaking to, Melissa, has been a really a great advance. And then, you know, stuff, going back again to that first question, stuff around HIV treatment and PrEP, and how we now are really talking about treatment as prevention and you know, sort of PrEP as a way of sort of, at least in this country, sort of ending the epidemic of HIV. That's huge, right? And not just for the disease itself, but because of all the conversations that come out around sexuality and sexual behavior and how that contributes to mental well-being and health, kind of come out of that.
May I ask you to clarify PrEP for the audience?
Oh, sure. PrEP. So PrEP is pre-exposure prophylaxis, which is taking a pill on a daily basis in order to prevent infection if you are exposed to the HIV virus.
Could I continue a little bit? So, two things. I'm sorry. So, two things. One about that the onus of, or to be able to identify myself as a sexual person, that shouldn't be all on me. It should also be with the provider. And I absolutely agree with you. However, I have learned in life that I too have to be responsible for my healthcare provider knowing as much information about me to give me the best healthcare that I can get. Knowing that when I walk into my healthcare provider, I say right up front, I have it memorized in my head. It's on the tip of my tongue. I don't have to have any anxiety about what I'm going to say, is that I am a member of the LGBTQ community. I'm a gay man. And I learned that in part because years ago, I've been with my partner for 48 years, and we've been married for 12 of those 48 years. But we started our lives together at a time when I would be afraid to out myself. So, well, the urologist would say, well, how does your wife feel about it? And I would, well, you know, and I thought, here I'm about to lie and deny this enormous aspect or part of my life. And so one day I said, I cannot do that anymore. And I said, what makes you think I have a life? I am married to Stephen G. Levine. He is my spouse and I am his. I'm not his husband and he's not my husband, though many people prefer that, and there's no judgment about that. It's just that we have decided we do not want that to be the language that we want to use to identify our relationship. So I shouldn't have to do that. And I'm very relieved when I walk into a healthcare provider's office and they don't make that assumption. You know, I don't have to be anxious about being combative, and I've got to say this right up front, because if I wait, I won't be able to say it the third or fourth visit. You know? So, I go to one doctor, I don't say anything, my blood pressure is off the charts. I go to another doctor in which it's all right and my blood pressure is normal. I mean, you know, come on, folks. It has that kind of impact on us as individuals. So, and sometimes, you were talking about the intersectionality in our larger society about individuals. So I was saying it once before today about sometimes how I'm treated in the helping profession. I say to myself, are they treating me that way because I'm black? Is this an act of racism? Or are they treating me this way because I'm gay? It's an act of homophobia. And then I ended up having to say to myself, it doesn't matter. It's wrong, and I'm not going to put up with it. So the teaching people, it is on both sides that we say to people, be an advocate, first for yourself, inside of yourself, and then be an advocate for yourself wherever you are in your life. And it would be great if you didn't have to. And it would be great to have the expectation that people in the mental health or medical profession is going to be understanding and do that for us. But folks, we can't wait. We can't rely on the fact that I would expect it of you. That's my take on it. But of course, I lived through the civil rights movement, you know, so I'm sort of feeling feisty about these things related to myself.
I think that's a really good point. Like, and kind of thinking about what you were saying about people are, I think, becoming more willing to advocate. There's more of a kind of community that will help people to advocate, help people to feel pride in their identities and feel comfortable saying, hey, this is who I am. And that's been a huge kind of strength of kind of the LGBT rights movement that's been happening. And kind of noticing the people who may be more on the fringes of that movement, who might have a harder time getting acceptance even within LGBT communities, such as bisexual people, trans people, other people of other identities, including like asexual people who just aren't attracted to anybody, might feel less belonging and then might have a harder time kind of developing that self-advocacy and feeling comfortable saying, hey, this is who I am, especially if they're not partnered with somebody of the same gender and are never in that position of having to correct a partner gender assumption, but there's still assumptions that are being made about them. A lot that goes into that. But yeah, I also want to note kind of what you're talking about with the stigma and minority stress. There's been research showing that legal protections are kind of directly correlated with people's mental health. So LGBT people in states in areas that have more protections are generally having better mental health. People who are in states or areas that have more kind of discriminatory policies or fewer legal protections tend to have worse mental health. And the fact is, even though we see a lot of bad news in the media, things actually are getting better. There are more laws being passed that are protecting LGBT people, successes for LGBT people. So I think that actually is something that's kind of helping to advance LGBT mental health, that we as a society are getting a little bit better at supporting folks. I also want to note the kind of increase in trainings that I think have become available. So I'm hooked in with the American Psychological Association. They have a huge division that's specifically about LGBT issues and looking at gender and sexual identity. And there's so many trainings that are available on all kinds of topics now with queer people of color and bi health and trans health. And it's really incredible that there are so many opportunities to learn about areas that people in the past may have had a very difficult time learning about. So I think that's been a huge advance. Although I think the people who are opting to take those, because they're always optional things that you're doing in your spare time, right? So the people who are opting to take those are often the people who are a little bit more knowledgeable already. And then kind of thinking also about advances that have been happening, just that we have a stance that therapy that's specifically trying to change somebody's sexual orientation or gender identity, conversion therapy, the APA has taken a stance saying, there's no evidence that's helpful, there's actually evidence that that's harmful. I think that's been a huge kind of move that's happened, that there's kind of an increasing recognition that it's probably not a helpful thing to do to people, especially if you're forcing people into it.
Thank you. What do you all see as avenues to advancing healthcare access and implementation? That is, where do you see your respective fields going in the next few years? Do you want to start, Tim?
Sure. When I was thinking about barriers, and I didn't mention this, but that sort of lack of training and lack of education. I mean, you're sort of speaking to that, Melissa, right? That for me is one of the biggest barriers to good and accepting and affirming sort of healthcare for LGBT populations. The fact that in a 2014 survey of all of the medical schools in the United States and Canada, the average number of hours spent on LGBT topics, LGBT, the whole area, was 7.5 hours in the 4 years of medical training. That's pretty incredible, and that's better than it was in the 90s, right? And certainly better than it was when I was training as a medical student. So I think education that is key, right? Kind of really fighting for and advocating for more education, better education of medical and mental health providers around these topics. For me, just kind of from a sort of my sort of own wish list around sort of LGBT health, I think in terms of the LGB, a lot of this is really about, I think, recognizing that LGB healthcare in many ways is really not different from healthcare for other people. That the stuff that creates the conditions that create special situations for LGBT people are all about the stigmatization and discrimination and the impact of that. And that hopefully as we move into a future where that is where there is less of that, that the whole area of LGBT health may become sort of obsolete. I think again for trans health, there's we're not as advanced in trans health as we have sort of become in LGBT health, and there are sort of more specific issues around trans health that I think are very particular to the field. I personally hope that at some point we develop better and more directed sort of gender affirming therapies, with both hormonal medications. I mean, right now we basically throw male hormones at transmasculine individuals and throw female hormones at trans feminine individuals and hope for the best in some ways. And I can see a future where we have more directed therapy that really is looking, may sort of produce specific feminizing or masculinizing effects that kind of really speak to the person's individual and unique identity. At the same time, and I think not really contradictory to that, I think, as we move towards the future in trans health, I think we're moving away from pathologizing trans and gender nonconforming people, but we've kind of medicalized gender so that sort of when a trans person comes to a medical provider, much the way HIV was at one point, right? So somebody who's trans-identified or genderqueer who comes into a medical provider, the medical provider immediately goes to hormone therapy and surgery, and so what hormone, you're looking for hormones, you must be looking for hormones. And I think sort of moving away from that medicalization of identity is something that I think will be is something that I hope will happen as we move along and advance in this field.
I suspect that my personal wish in the advancement of healthcare for the LGBT community in my profession would be a stronger recognition and appreciation of what a person's spiritual life has to do with their healing. To acquire spiritual language as opposed to religious language, to help amplify and shed light on the spiritual side of individuals as a whole person. We are also, in different degrees and in different ways, spiritual people. And that seems to sort of not be appreciated for the power that has in helping people come to changing behaviors, appreciating their own goodness, the goodness of the earth, the goodness of trusting in individuals, all the things that can come about with a spiritual life that's nourished and truly appreciated and called attention to. And so that's one of the advancements that I hope continues to grow in terms of the therapeutic community. Oh, I also forgot to say, when you were talking about government, how we have advanced in our services from the government. I mean, many of you may know this pamphlet that says Department of Justice, Civil Rights Division, protecting the rights of lesbian, gay, bisexual, transgender, and intersex individuals. As a part of, no matter what the political system may look like, there are places within the government system where they are trying their best to be allies with us in our own protection. So that's just here.
Yeah, so one of the things that we've talked a lot about, and it's so important to talk about, the kind of stigma and stresses that LGBT people experience. And I think you're spot on talking about the need for more training, more awareness of those challenges. But one of my friends was recently talking about how, really when everybody who says that they want to work with LGBT populations makes it sound like LGBT people are just like sad all the time. And that's not true. So I think also kind of recognizing the different strengths that LGBT people might have and the strengths of those communities, thinking about resilience, thinking about pride, thinking about the ways that having questioned your identity and kind of figure out who you are can lead to a stronger sense of self or more open-mindedness, egalitarian values, advocacy. There's a lot of positive things that can come along with being LGBTQ plus identified. So I think kind of increasing the conversation about those things in combination with the stresses and the stigma is really important. Also kind of thinking about increasing access, the first thing that kind of came up in my mind was thinking about the barriers of access just in terms of oftentimes therapy is hard to get to, not very affordable. So honestly, just making mental health care more accessible in general, offering more free and discounted sliding scale kind of mental health resources, I think is hugely important for all people, but especially would be beneficial for LGBTQ community. And then, as I was talking about before, and I think there's progress in this area, asking about identities and getting a sense of who people are as a standard part of an intake process.
And I also think about telemedicine in terms of that accessibility, right? That telemedicine is a field that's just starting to be explored and really can provide, really great and necessary healthcare to people who are socially and geographically isolated.
Thank you very much. At this time, we're going to invite you, the audience, to ask questions of our panelists. And we'll have a couple of microphones being passed around. Any student volunteers to help with microphone? Oh, sure. Anybody want to volunteer? Yep.
So the panel as a whole had discussed how the healthcare models for the LGBT community had almost run in parallel to the quote unquote standardized healthcare system. So it was two separate models. In the future, do you see going forward those two healthcare models merging into one by saying that the majority healthcare system is raising its standards and its expectations to the point that it can accommodate all in that it's there to serve, or do you see the two always kind of running in parallel because the needs of the LGBT community would always kind of be a separate sect of the healthcare system?
Great, that's a great question, actually, and I think, it's my hope, and I think my expectation. So again, going back to this idea that I talked about, I think in the first question, and we were talking about at dinner, how sort of working in these what are seen as kind of specialized fields that really deal with really kind of core things about our identity and about our health helps to kind of explode boxes and helps us to provide better care to all of our patients, right? So for instance, in terms of education, I think, what happens in education right now is you get these, you get a day of LGBT health, right? Or you get a short section on LGBT issues within the context of another, like for me when I was in medical school, it was our psychology rotation, right? So, and I think ultimately what needs to happen is that we need to sort of be talking about LGBT people and patients and health kind of in the context of all the different areas of medicine and all the different areas of training. And that's really the way to kind of create better health for people. And I think that will happen also in the larger field of medicine, that as we become more comfortable around these issues and as we continue to talk about these issues, as the people working in this field kind of continue to sort of put it out there and normalize all this stuff, that yes, I think ultimately LGBT health as an area and as a field will hopefully become obsolete, and it will just become part of good health care. And I do really believe that that's possible.
Other questions?
So one of my questions is that as a gay man for many years working in psychiatry, one of the sensitive issues is sex itself, which is a very difficult thing to discuss. it sort of loses something in the translation as a gay man when you go to a primary care physician who really doesn't have any background or understanding of what our culture is really like, and then to sort of be able to speak openly about what it really is like sexually for gay men. How do you think that will sort of change or infiltrate into general practice where people feel more comfortable around the actual, sexual part of that?
Well, I only know for myself that I certainly have sought out men's health facilities that really dealt with and were staffed by gay physicians that I imagined that they knew what I was going to say or talk about, or the language, we could find a common language, or I could say, I don't know the medical term for this, so I shall say it as I say it to my partner or to a friend, to be encouraged to use the language that you can first start off the conversation with. Because it is difficult sometimes to talk about the intimacies of sexual behavior and acts. But those are the devil can be in the details sometime, and those are the real things to be talked about. And to find someone who can allow and share and help you define what your health needs are or concerns are. That's how I did it.
Yeah, I think that's one of the areas that there's still a lot of room to be growing in. I've had conversations about the training in my program, tends to be about, here's like stigma, to learn about like the stigma that these communities experience. And there's nothing about like different kind of cultural practices or sexual practices at all. So for people in my program who don't have direct experience with that, aren't going to go into the field knowing what people are talking about if they come in and start discussing those things. So that's definitely still an area where I see deficits of room to grow. And I think with the advances of LGBTQ plus mental health care, there's also started to be some advances around kind of more diverse sexualities. So like right now I'm part of a task force that's looking at consensual non-monogamy, so kind of open relationships and different kinds of like sexual relationships people might have. And part of what that task force is looking at is, how do people talk about sexuality in those ways? And I'm hoping that will kind of feed back in to then benefit our like wider ability to talk about sexuality in general.
It's a really great topic for you to bring up, Lionel. And I think, it's interesting because the discomfort with sex is so systemic, right? Like, I have been with medical providers who, like, I saw you out in the club on Saturday night, and here now you're tisking and waving, like wagging your finger at people about things. That there's a disconnect there, and you put on that professional sort of demeanor, and all of a sudden you become a sex cop, and I think really actually the conversations around the conversations around HIV and treatment as prevention and PrEP are starting to kind of move some of this forward a little bit, and I think really starting to force the conversation around how the joy of sex and how it sort of connects us and fulfills us is really a huge component of our well-being, right? And I think those conversations are starting to happen, but with people sort of dragging their feet, kicking and screaming a little bit. So.
I was just wondering if, as we advance LGBTQ healthcare, if you had any advice or thoughts about how to bring racial equity into that picture, because I feel like if there are still disparities between a trans white man and a trans black man, we still haven't really done all that much.
I'll speak.
Go ahead, but I'll also.
Clearly there's an issue, right? I mean, so for trans women of color, the rates of HIV infection approach 30% in some populations. A trans woman of color is 30 times more likely to die of her HIV infection than somebody else with HIV, right? And those statistics are out there and I think are starting to be looked at. I know in some of the national conferences, these concepts of intersectionality and how race impacts both sexual and gender identity and the stigmatization of both identities, how that leads to sort of negative health outcomes is starting to be talked about. But we haven't become very sophisticated around that yet, I think.
And we haven't become easy with acknowledging many of the myths around race and sexuality. I can clearly say that I don't know how I knew it, but I knew the myth about black men and sexuality. It was a myth, and I knew it was a myth. But there was power in the myth, and the one thing I was taught was don't destroy the myth. I don't know if I'm being clear about what I'm talking about. And so because I wasn't to destroy the myth, there were certain things I couldn't talk to my health provider about. I had to behave in a certain way because it was expected of me as a black man in terms of my sexuality. And so there were parts of me that was still not available to be in the best service of my health care. So we also need to talk about the myths of these issues of race and sexuality and how they hold us hostage to how we see and treat each other in the medical and the mental health profession.
Yeah, I can say from kind of research perspective, I think most of the research that's done still uses predominantly white samples, which is a huge issue. I think someone's perspective is like, let's study this in general first, which means like, let's just study this with the easy to access white populations. And then later we'll look at, the needs of specific other populations. And it's a huge issue. It's something I think is becoming more of a conversation and people are beginning to talk about more, different methods that we might be able to use to address that. But I'm really glad that you brought it up.
So this question is sort of directed more towards Dr. Cavangh, but obviously anyone can chime in. I was just wondering, since you work in trans health, I was curious how you guys would go about treating or providing healthcare for a younger person, more like a minor, like a child, because sometimes, I don't know, I feel like I've heard stories about healthcare providers sort of struggling with that because they're children. They don't necessarily know how to go about, caring for the children properly. Yeah. Not to say you can't do that, but you know what I mean.
Yeah, no. That's actually an excellent question. In fact, I had adolescence written several times in my notes here and didn't speak to it, but I think we are, from a medical perspective, we're starting to understand just how important gender identity and sexual identity are, as we sort of develop into our puberty and develop as children, and that how incredibly important it is to support kids who identify as as not heterosexual or not cisgender. As Melissa can probably speak better to than I, there's all sorts of data that sort of parental acceptance or school, sort of support in the schools, having one sort of adult that sort of supports you, so it might be your medical provider, can be so impactful and so important to kids who identify as transgender, certainly, and also as gay or bisexual or queer. So I think the field is starting to kind of come to terms with that. There's a lot of discomfort around, especially for trans kids, right, and genderqueer kids, about how do we identify those kids who are really trans, or who are going to persist, who are the persisters or the desisters, and not sort of kind of impose medical regimens on them, like hormones or surgery, that they might later sort of come to struggle with or regret. The reality is that there's very little regret, that kids know pretty early on who they are, and an adolescent who is telling you, no, this is who I am and this is what I need. We need to listen to them more. I think the hardest part of that is really managing their parents, right, and supporting their parents, right, and supporting the other systems like school systems and things that are so important to kids at this age, right. So I'm losing track a little bit of your question, but I think the field is coming to terms with that. The field is coming to understand just how important that is, not just from kind of a physical perspective, like, right? Because if you can start to affirm somebody's gender with hormones when they're an adolescent, before they develop all of their unwanted sexual characteristics, right, their physical and anatomical characteristics, their life is going to be really a lot easier for them at some point, and that's really important. But I think also just the ideas and the concepts around mental health and sort of affirming identity and how important that is for kids at this age, is starting to be talked about more. And although there's resistance, the conversation is moving forward really at actually a pretty fast pace for medicine anyway.
I have a question about language, like okay language to use when asking and like wanting to know more about the LGBTQ community, like saying if you have a friend that identifies as LGBTQ, how would you go about asking them like about their sexuality, like what is okay to ask?
Yeah, so that's a really good question. I think it always depends a little bit on context. So if your friend hasn't actually like raised the topic to you and you're just coming up to them, it might be a very different conversation than if you're working with a client as a provider and what that conversation might look like. So I think one of the first things, if they're not bringing it up to you, if you're just wanting to understand them better, is first asking permission to ask, saying, I'd like to know more about your experiences with this. Is it okay if I ask you some questions? And then saying, kind of leaving it kind of open-ended and taking a non-judgmental stance of, can you tell me about what is your identity? What does that mean to you? What does that look like for you? And letting them kind of fill in the language and then using the language that they use. There's also really useful internet resources that are not going to be universally true. There's always disagreements about what languages people like, but it can give you a good idea of kind of what are some outdated terms, some terms that might be offensive to people now. Like homosexual used to be used a lot, and a lot of younger people, especially nowadays, are really uncomfortable with that term. Same thing with like transsexual, still used sometimes, but there's a lot more discomfort with it than I think there used to be. So just kind of doing some education on your own first too, to see what do the language trends seem to be. I think are all things that can be helpful.
Yeah, I think your point about, so when I talk to medical providers and when I also talk to people at parties and stuff, I think some of it is what is the information that you need to know here, right? I mean, ask me all the questions you would ask anyone else before you start asking me if I take hormones or if I've had surgery, or if so some of it really is about sort of affirming the person as a person before you start digging down into what their identity is. But I think you're right. Sort of being careful not to use gendered language, being careful not to use sort of cis-normative language, right? Trying to ask broader questions, right? Like what is sexual attraction like for you? Who are you attracted to? When I'm talking to people, it is about what kind of creates joy for you around this, and what kind of creates sort of excitement, and what's not healthy about these things for you, right? And around gender identity, it's not trying not to put people in boxes, right? And not asking them to identify as a particular thing that in your head you're making assumptions about, but allowing them to sort of kind of explore their identity with you and sort of responding to those kind of questions.
And sometimes for me, it is when you ask me a question, I think, what is the question behind the question? What is it that you really want to know to attach to some other information you have to build your own knowledge? So it might be helpful to say, well, I'm going to ask this question, but the question that I have behind that is, so that people will be able to trust that you are bringing forth what's the meaningful information that you would like to have or share with them. Because, we ask a question because there's another question behind that. And if you don't tell me that, then I don't know that I can trust you. You're asking me this, but what is it you really want to know?
My question is for Melissa, and I'm wondering if for bisexual women in committed relationships with men, if you see an increase in domestic violence, and do you know if there's a difference between in rates of domestic violence if the woman is out or not?
That's a really good question. I don't know specifically the answer to that. What I do know is that the rates of sexual violence do tend to be much higher for bisexual women in general. I don't know of research that's looked at specifically who they're experiencing that violence from, and I think that's an area that needs to be looked at more. And in general, we know that men do perpetrate violence more often than women, so I would have some guesses about what that might look like. And that question about whether they're out about their identity, whether that's kind of moderating the violence that they're experiencing, I also don't know, and I think it's a really important question. Thanks for asking.
The other part of that question that I think is interesting is sort of the fetishizing of identities too, right? About how we need to be careful about how we culturally and individually fetishize other people's identities, trans identities, and sexual identities, and bisexual identity, and really sort of help people to advocate for themselves in those kinds of situations.
What do you think of the belief that transgenderism is a mental illness?
I haven't thought of it as such. So I don't know.
There's actually been a lot, I think transgenderism as a mental illness, officially the concept has been thrown out, okay? But I think people still struggle with that, and do you all know what the DSM is, the Diagnostic and Statistical Manual, which is sort of a listing of diagnoses, mental health diagnoses, and the criteria, the diagnostic criteria for those things, right? And it was just with this newest version that the term gender identity disorder got thrown out, right? So that it wasn't the identity itself that was pathologic, it was the dysphoria and the distress that had to do with how that person sort of manifests and presents that identity to the other people in their life, and how they struggle internally with that, right? So that the illness, if there is an illness, is not being trans, the illness is struggling to be a trans person in a world that does not accept you and recognize you.
Yeah, so gender dysphoria is still in the DSM, so the kind of people having discomfort with their bodies, wanting medical transition, which to my understanding is because having it in the DSM makes it easier for people to access services, getting kind of medical transition services that might be desired if you're having that kind of dysphoria. And there's a lot of conversation, debate still happening about whether that's appropriate. Is there a way that people can still access services without pathologizing? Because I think there's kind of an increasing view that it really should not be pathologized.
Time for one more question?
Yes, we have time for one more question.
So mine had to do as a nursing major, so it doesn't apply to me, but I know in the coming years our NCLEX boards are going to be changing a lot in terms of questions being asked and just how the structures of it. Like I know our professor talked about today how there's going to be a lot more questions about like medical marijuana. So with like all these changes with like LGBTQ plus and like just more openness of the community, do you think it would be important for them to include maybe questions and situations about that, not only because it might be more prevalent in like healthcare today, but just because it's just something that you're going to see more as we actually become nurses and healthcare professionals?
I think I'd like to take that one. Well, I haven't seen you in class yet, so I will see you soon. I teach in the nursing department. And yes, I would love to see more questions on the NCLEX related to LGBTQ+. Not only on the NCLEX, but all standardized exams, textbooks, case studies. Our system right now, our education system is not, it's not equitable. And so that's reflected in standardized tests, it's reflected in our textbooks. So we have a lot of work to do. And I thank you for asking that question. And I do hope that when you do take your NCLEX, you will notice some diversity. Thank you.
Thank you all so much for coming tonight. Can we have a round of applause for our awesome panelists?